Hi, everyone. Thanks for coming, first of all. I think we're going to have a few more. We tried to hold out because we know food people are walking over, but health is a big place. So we'll start just going through the presentation. We also have a surprise guest that is already online that will walk through some of the case studies. So firstly, you may or may not already know us. Dyania Health. We automate what is otherwise a manual process for chart review in what would take a human an hour to 2 hours in some cases, down to half a second on 2 GPU. So our mission from day one, and this was end of 2019, beginning of 2020, was, clicker misfunctionality. There we go. I'm going to not touch this for a second. Mission from day one was to automate what is otherwise a manual process and train a large language model that we spent the pandemic creating data sets and annotating those data sets to train the AI to perform. So automating manual chart review, which is one of the most time-consuming and inefficient processes in healthcare. And effectively, we've done this now in production, and so we are past what is otherwise across the industry of AI very much an experimental process, and we've got some fantastic results that we're going to run through today. As many of you may or may not know, medical records are extremely unstructured and have an immense amount of free text that needs to be reviewed across an EMR database. So typically you'll have medical personnel, including nursing staff, physicians, et cetera, that are going through EMR systems and finding patients' medical records to answer certain questions that would be relevant from a clinical research perspective, as well as abstracting and doing manual chart review for registries as well. We built Dyania to combine what is, in many cases, often trying to be solved by an engineering team, and the sense that we wanted to combine a deep computational acumen with a full-time team of physicians. The team has been brought together from AI research backgrounds from Bloomberg AI, Amazon, as well as a few other big tech companies that are pretty well-known names on this page. Our engineering, which differs very much from the AI research, is the plumbing behind the entire setup, where we are gluing all of the data pieces together from over 83,000 data types within a healthcare system's firewall. So the entire process is automating the reading within that healthcare system's environment without ever removing the data from that firewall. Our team came together in a very conscious effort to solve this problem, and so it's been a long investment of us working on this through the pandemic. The result is that we were able to launch, and we're not forced to launch prematurely, in a way that would, in some cases, dishearten the medical community that has high demands for perfection. So we were able to launch towards the tail end of the pandemic with a model that performs at above 94% accuracy vis-a-vis human physician. We've now tested that in a real environment, so it's not just our clinical teams giving those results, but those numbers are validated by healthcare professionals at a few key healthcare systems across the US. We'll go through a little bit of a video of how it works. So firstly, Synapsis AI is the model that we trained. It's been trained in the same way that a physician would be trained, firstly on medical text, and then on cases that have been completed by our clinical team with about 30 minutes per medical record case, where they're answering questions. Now, the specific questions, and we might have a Wi-Fi problem here. Oh. Okay, hold on a second. Video is not loading for some reason. Okay, we'll get to the end of this video. Come on. All right. Technology is not working in our favor today. We'll just get to the end of the video then, so you can see the results. So basically, the entire focus of what we wanted to do, hold on. there we go. Was make sure that we had trained our AI model to not only answer questions that were relevant about the patient's medical record, but to be able to provide the justifications that would pinpoint the part of the medical record that led the AI to deduce those specific conclusions. Therefore creating a level of explainability, but also an auditable trace into where it's coming from and removing that black box. This is extremely relevant in the field of clinical research, where it's not just the answer that matters, but why the physician had gotten to that result. What you'll also note here is that the answers are often being combined from a variety of sources. So there could be a part of a note that's written in one paragraph and another piece of information that's written in a completely other note on a completely other day that allows the AI to deduce a singular conclusion. So it's combining information from many parts of the EMR in order to reason through a chain of thought and deduce a singular conclusion. What makes a question or answer hard or easy is actually how complex the information is described in that note. So in some cases, a note might explicitly state that a patient's certain characteristics are defined, and in another note, it might describe an order of events in which a human would be inferring by deducing all of those conclusions, and a chain of thought would allow them to finally arrive at a singular result. We look at this across the field where effectively, in this case, a hard question would not be defined by the question itself, but by how complex the information is described in the note. So for example, here, we're looking for when the patient's most recent small molecule therapy was administered. That can be an easy question because in one note, the physician might write that they were given their last therapy on November 23rd. But it might be a hard question to answer in another note because the physician might write that they had their last small molecule therapy on November 23rd because the patient had their last fever episode on November 12th. The last paracentesis was 8 days after that, and the last treatment was 3 days after that. And so an AI or a human would have to read through that entire history to deduce that order of events and arrive at the conclusion of November 23rd. And so it all depends on how complex the information is described in an electronic medical record. Our AI system is trained to perform across all levels, and so effectively the 94% that we advertised previously is performing at even the difficult questions, which is quite unique in the space of healthcare. So this is not something that you can just throw a ChatGPT at and solve the problem for. It's been years and tens of thousands of hours of our physician team annotating these cases to train the AI to solve for exactly this specific problem. So how we've trained the AI is very similar to how you would train a physician. So we first give it a medical degree by training it on medical school textbooks, up-to-date scientific documentation, medical text, drug dictionaries, etc. As the field of medicine changes and state-of-the-art information comes to light, we are retraining our models quarterly so that it is staying up to date in terms of the latest standard of care procedures. The second level of training is what we compare to an AI residency, and this is where we have our AI being taught the cases that our physician team, our clinical team has annotated. And so basically where our clinical team would have, starting with an EMR note, provide a question, answer, and a justification for that answer. That's the defined ground truth. So it's a case that gets fed to the model. We view a set of 10,000 cases as equivalent to an AI residency in a certain disease area. And so we build cumulative residencies onto our AI as it starts to advance and become triple and quadruple board certified. So we would think about this in a very different way than you would look at a generative model that's starting to generate text or summarize text. In this case, we're looking to understand and draw conclusions in the same way that a physician would. So just to highlight a few of the case studies that we've done and in production, and we're actually producing results. I have a guest that's going to join in a few minutes, but we'll first highlight a few of the results of a clinical trial that we were screening for patients for a rare cardiovascular disease. So in this case, and actually I think maybe before we go through the whole video, we might want to do a quick introduction. So I'm just going to switch over because we've had a little bit of technical difficulties. 1 second. Trey, do you want to join in? Okay, let me get you on main screen. 1 second. Goes over there. Hold on, losing the mouse. Oh, there we are. Okay, isn't that? Can I remove the other participants? Okay. Trey, can you hear us?
Yes, I can hear you.
They took over, so they need to check. Okay, perfect. Do you want to introduce yourself and a little bit about the work that we were doing with amyloidosis?
Sure. So I'm Trey G. Martin. I'm a heart failure transplant cardiologist at Cleveland Clinic's main campus. Can you guys see me and hear me okay?
Yep, we are just going to remove the other participants from viewing. View. Yep, there we go. Okay, you're live. Maybe start again.
Okay, yeah, so I'm a Trey G. Martin. I'm a heart failure transplant cardiologist at Cleveland Clinic's main campus. I'm also director for cardiovascular population health for the health system, and I'm a clinical trialist in our clinical trials group in the Heart and Vascular Institute. And so my collaboration with Dyania was across 3 prospective clinical trials, one of which is being highlighted here in a rare cardiomyopathy of older adults that causes heart failure called amyloidosis. And so I'll let Eirini kind of highlight this video, and then I'll circle back to the results that we found.
Excellent. Okay, and we're just going to switch back over to the presentation. Okay. All right. So firstly, we're starting off with a clinical trial whereby the questions that are being asked of the AI are looking for specific characteristics within the patient population. So here we have just looking for a diagnosis. We could be pulling that from multiple parts of the medical record, and you'll see where it will highlight and source the exact part of the EMR that led the AI to give the result that it gave. These conclusions, in some cases, will prioritize structured data, meaning the labs or any type of diagnostic code, as well as what could be found specifically in the notes. Also, you'll see here that the notes can be coming from many different parts of the medical record, allowing for a singular conclusion in this case. I think we have, there we go. So moving along, effectively, just to go back. Okay. Yep. So here we wanted to highlight overall that we're able to find patients on specific criteria where they're accepted, borderline, or in some cases missing information. The borderline is one of the most crucial components because we're able to find patients when they have just been on a therapy for long enough to where they could get flagged by a physician, but not yet having a full criteria matching element. So let's say we're looking for a patient who's been on a certain therapy for 16 weeks, and then that patient has been on for 12. We want to get ahead of the ability to enroll that patient in a study. Overall, the results of the patients that we found were for screening, let's say for starting off with the 4.7 million patients at Cleveland Clinic. The first levels of the screen within the funnel are in 1.2 million patients with active cardiovascular conditions, and then 156,000 with heart failure, with an ICD-10 code for heart failure. In some cases, diagnostic codes can be wrong, but what we were focusing on here was how to optimize for the computing power that's processing these patients. And so the large language model effectively read through 1,476 patients to find 30 patients during the first week of going live. And I think maybe, Trey, we can not go on video, but do you want to walk through these results?
Yeah, sure.
Okay, perfect.
Yeah, so again, this is a pretty rare disease in older adults that causes symptomatic heart failure. And we were doing a study of a novel therapy that can actually remove the amyloid protein from the heart muscle. And so in order to kind of set this up, Dyania had to kind of integrate with our EHR and then map where all the data lives, including lab data, echo data, clinical notes, et cetera. And what we found is that in 1 week, they were able to use the LLM to review around 1,500 charts. And in those 1,500 charts that have been pre-filtered using ICD codes, they found 30 unique patients who were very likely to match the clinical trial that we were running. And if you put that in the context of what we were doing through manual screening for clinical trials, which we found 14 unique patients over a 3-month span, obviously very much increased in efficiency. And when the findings of the large language model Synapsis AI was compared to, kind of a physician review of the matches that they found, we found very high fidelity in the medical conclusions they were drawing, actually 100% accuracy in the 30 patients that they found in terms of the medical conclusions they were drawing. And I think what's very exciting to me about it as a clinical trialist is that we're under pressure to do more research with less resources, given research nurse coordinator shortages at our center and around the country that have persisted after the pandemic. So it was exciting to see that they were able to do this quite quickly. And I think in discussion with the Dyania team, one of the limitations we had is that we have 2 GPU on premises to be able to do the analysis. So we had to somewhat pre-filter, probably more than is ideal, using billing codes to get to the 1,500 number. Now, if we'd been able to use their LLM on all 156,000 heart failure patients, I imagine we would have found even more patients than we did. And so I think, very exciting preliminary results from my perspective as someone who runs clinical trials and likes to use health system data to be able to try to find a broader swath of patients.
Perfect. Thank you so much, Trey. Just to also recap on the overall results, and this is what we've seen across both the oncology space as well as cardiovascular, which we just touched on. We are hitting about 94-95% accuracy. That's compared to Cleveland Clinic physicians and nursing staff, not necessarily just our own clinicians. So those are the other preliminary results we're pretty excited about. And then lastly, on our list that we wanted to touch upon are really the use cases around this, because it's not only capable of finding patients for clinical trials, but also for observational studies. We're able to determine queries quite quickly to find how many patients would exist in a theoretical clinical trial. So for study feasibility, registries and reporting automation, as well as finding certain quality of care and therapeutic gaps. And then we accidentally often stumble upon medical misdocumentation as a process of what we do. So that's the overview of Dyania. Now, without further ado, I think a few of you may have been aware that we are going to make a fun announcement today. So we'll open it up to questions after that, but just to highlight, and firstly, want to thank Todd and Laura who are here. But we are excited to announce our Series A that was led by HealthX with participation by Cleveland Clinic Ventures as well as TechSquare Ventures. So thank you guys for all the hard work, and that's for our offline announcement. So we're excited for next steps and what the company is building. So.